The use of NSAIDs in the acute ligamentous soft tissue injury setting is detrimental to long-term healing and increases the probability of long-term problems. And it's interesting because they've now shown that NSAIDs increase the probability of non-union fractures. They just haven't translated that information to the ligaments, but really there's a tremendous amount of overlap between the bone recovery, healing response and cascade and the one from ligaments. And so the same principles are probably true, it's just harder to show with ligaments. If you've got a broken bone, okay, 6-8 weeks later, whatever, did it heal, did it knit or not? That's easy endpoint for your study. But when it comes to ligaments, it's much more subtle. Even with MRIs, it's kind of hard to tell if something healed up right or not. And so what we do know, I mean, the orthopedic community is increasingly avoiding NSAIDs in the setting of fractures. The same should also be true in the setting of ligamentous injuries.
Hey friends, it's Mike Mutzel here. Thanks for tuning back into another video. We're live with my friend Dr. Shawn Naylor, and we're going to talk all about prolotherapy, regenerative therapy, and how to really restore health of the knees and elbows and things associated with sports injuries and age-related osteoarthritis and much more. So, Dr. Shawn, it's awesome to be with you in your clinic. And
thanks,
for folks that want to see the demo about like prolotherapy on a real human being, click the link below this video. We'll show the footage of that. But first of all, let's kind of launch with what is prolotherapy.
Well, if you break down the word, prolo is for proliferation. So basically the intent is to use an injection to cause the proliferation of connective tissues to enhance the structural integrity of something that was weak or loose or unstable or damaged in some way.
Yeah, and so the idea is you're injecting a solution of sorts. And we'll talk about the solution, but what I think is pretty fascinating on some of the randomized placebo-controlled, quote-unquote, placebo-controlled studies, just the trauma of injecting the needle actually causes some of the therapeutic efficacy. So let's talk about like the needle trauma and then the addition of the different ingredients within the Prolo solution potentially.
Sure. Yeah, I mean, I think one of the reasons why prolotherapy just hasn't garnered the acceptance that it deserves is that many years ago, it could have been 50 now, we were trying to do more research on prolotherapy. One of the criticisms was that there wasn't much in the way of double-blind placebo-controlled in terms of having a sham treatment group where those patients actually received injections. And so the criticism is going to be, okay, well, only one group got the injections. Everybody knows when they got an injection, so it's not a true placebo group unless you have that. And I think what they didn't realize back at that time was just how important the needle trauma itself is to the efficacy of the treatment. And so they were using, I think, dextrose versus a saline solution. And what they noticed was that both groups responded well to treatment, and the statistical difference between them was small. And so then they said, oh, look, it's not much better than placebo, it doesn't work. Mm-hmm. But in fact, both groups had received a treatment. The doctors were blinded too, so they were doing what you should do when you're doing prolotherapy is use the needle to create some trauma. And when you're using a small, sharp needle, you're not going to cause significant damage to a ligament, but you will make it bleed, and that creates the perception of an injury. The blood causes an inflammatory response that recruits fibroblasts, hopefully to lay down new collagen and shore up that structure so that it's closer to its original length and strength pre-injury.
Yeah, and you were saying that it used to be called sclerotherapy.
Right.
Why is that?
Right. So again, when they were first working with this, and I think it was potentially 60 or 70 years ago now, the Hackett-Hemwall Foundation still exists in memory of the sort of leaders and pioneers who thought that they were creating scarring. And so their idea was, okay, we've got ligaments, they're damaged, they're frayed, they're partially torn, they're not making a good solid connection to the bone. We're going to go in there and treat them, and they're going to scar down and become stronger, because that's what happens to your skin. Mm-hmm. Yes, you've got scar, and under a microscope the scar looks different than healthy skin. But it turns out that ligaments don't heal that way. A ligament that has healed is indistinguishable from a healthy ligament under the microscope. And so that's when they kind of decided, okay, we're not causing scarring here. We're causing proliferation. So we're not going to call it sclerotherapy. We'll call it prolotherapy.
Mm-hmm. Interesting. But I think the important point to reinforce here is what we're doing is it's like an endogenous, or we're causing the body to enhance its own recovery in a sense. So it's not like an NSAID or other anti-modulatory, immune system modulatory drugs in the sense like we're trying to suppress the immune system. We're trying to actually create a little bit of microinflammation that will cause healing over time.
Right. That's absolutely true. And I think there's something that deserves to be said just about NSAIDs. Probably are a part of the reason why so many people need this kind of therapy in the first place. And so when you injure yourself, an inflammatory response is triggered, and that creates a cascade of events that plays out over usually 6 to 8 weeks. And if you block the inflammation at the source in the early stages, the amplitude, the amount of healing response that you're going to get to that injury is going to be diminished. And so probably the use of NSAIDs in the acute ligamentous soft tissue injury setting is detrimental to long-term healing and increases the probability of long-term problems. And it's interesting because they've now shown that that NSAIDs increase the probability of non-union fractures. They just haven't translated that information to the ligaments, but really there's a tremendous amount of overlap between the bone recovery healing response and cascade and the one from ligaments. And so the same principles are probably true. It's just harder to show with ligaments. If you've got a broken bone, okay, 6, 8 weeks later, whatever, did it heal, did it knit or not? That's easy endpoint for your study. But when it comes to ligaments, it's much more subtle. Even with MRIs, it's kind of hard to tell if something healed up right or not. And so, unfortunately, I think that what we do know. I mean, the orthopedic community is increasingly avoiding NSAIDs in the setting of fractures. The same should also be true in the setting of ligamentous injuries. And it's also true that if somebody is about to get a prolotherapy treatment or just got one, they shouldn't take NSAIDs. Sometimes the procedure hurts, sometimes the recovery can be painful. In those settings, it's appropriate to use Tylenol, maybe even something a little stronger, but not Advil, Motrin, Aleve, ibuprofen, these NSAIDs that probably in the same way they diminish the healing response to the initial injury may diminish the healing response to the treatment.
Very interesting. So, but Tylenol's in a different category, different medicine. It's an analgesic of sorts, not so much affecting the immune response in that way.
Correct. So Tylenol or Tramadol's the kind of quasi-opiate that's not as dangerous or addictive, and then you're up into your Vicodin, Percocet. Those are opiates for the most part plus Tylenol. But yeah, that group is different from the Advil, Motrin, ibuprofen, which are all the same thing, and then the Aleve, naproxen, naproxen. Those are all the same thing. Aspirin is also technically an NSAID.
Mm-hmm. Salicylic acid and whatnot. Right. Very interesting. I think maybe we'll go back a little bit. I guess we didn't really talk about which joints. I mean, some of the research that I read was like tendonitis, myofascial pain issues, some osteoarthritis of the knee. There was like some randomized control trials that I found in PubMed. And the evidence was really strong from what I gathered, right? But what are the best case scenarios? Like someone has hip pain, will it be improved by Prolo? Joint, elbow pain, shoulders, like what? Is it all articulating tissues that benefit?
I think that just about any joint can be painful because of an injury to a soft tissue. Mm-hmm. And so just about any joint, therefore, is theoretically amenable. And there's not a lot of joints that I haven't, treated at one point or another. You kind of go with whatever comes through your door. But so I guess if you're a prolotherapy purist, maybe you're more interested in where ligaments attach to bone and hitting that spot and hoping that restores the structural integrity of whatever tissue you're dealing with. So you might imagine that if you have a a ligamentous injury in your knee that hasn't returned to its original length and strength, now you're going to have more play in that joint. And that increase in play is going to increase the amount of wearing on the cartilage. And so that cartilage is going to wear out faster. And so it may be down the road that your pain is more due to the lack of the loss of cartilage, and trying to, and so an appropriate treatment to that kind of an injury probably would be something that tries to shore up the ligament itself that was injured that is now lax, but then also. And so if you're a prolotherapy purist, maybe that's where you stop. But increasingly, in terms of treatments like Prolozone, which is sort of an offshoot that I'm interested in, there's a renewed interest in putting solution into the joint itself, where all your cartilage is, in the hopes that you're going to kind of shore up and enhance and improve and restore vitality to that tissue as well, so that it kind of comes back on board more quickly.
So that's what you did with the patient that was just in the room. So you did the cartilage and also the ligament, yeah?
Right, right. So I think he has some laxity in his joint. I think it's at least in part due to this lateral ligament. So I wanted to treat that to shore it up, and then I think a lot of his pain is actually coming from inside the joint where it's been lax, or where it's been wearing and moving around and not stable. And so yeah, I'm trying to treat that as well.
This is really interesting. So it's almost like a root cause resolution of joint pain, right? So the allopathic approach would be more interested in like scoping out the meniscus and doing things of that sort. But what we're saying is the meniscal issue or the cartilage, potentially bone on bone, could be really a result of a lax ligament. And you're treating both, right? Which is really unique. I've never heard anyone articulate that, which is fascinating.
I think sometimes cartilage gets described as a finite commodity, something that you're born with this much and you better not wear it out, but it's not accurate to think of it that way. It gets worn down every time you take a step, and it mostly recovers at night. And so at any given 24-hour period, you're going to wear it down a certain amount and you're going to build it back up a certain amount. And if you're wearing it down more quickly than it can recover, then you're going to start to lose it. And if you can shift that so that now, and sometimes you just need to shift it a little bit so that you're back on the forward side of that equation, then you can build it back up. And so that's one of the reasons why sometimes people who are really overweight, if they just lose 10 pounds, they're back on the winning side of that equation, and their cartilage can recover. And it's the same for a ligament that's maybe creating, by virtue of being loose, creating just a little bit more joint pain, and you can just shore that up a little bit, and now that joint play goes down a little bit, and now you're back on the winning team or whatever.
Very interesting. All right, so let's kind of walk through what's in Prolo versus just Prolozone. The difference in the therapy.
Yeah, so there's different providers use different solutions, and I think of PRP, which is platelet-rich plasma, and even some of the stem cell treatments that are now being used as different solutions used in the same manner. I think that in a way those things are all prolotherapy, and increasingly people are trying to get away from that term because because prolotherapy isn't covered and it's probably that ship has sailed. They're now trying to move on to some other modality that maybe they can create enough research behind and make it more mainstream. And I think that's appropriate, but I don't think there's a fundamental difference. So you're pretty much always going to use a local anesthetic. And for the most part, lidocaine is kind of the go-to in the medical community, and it's inexpensive. A lot of neurotherapists and some prolotherapists prefer procaine just because there's some evidence that's fairly old now, but still kind of compelling to me that maybe it's metabolized into less toxic things. Like the procaine is metabolized very quickly into an amino acid. It's totally non-toxic. Lidocaine, it's widely used. It's probably fine, certainly in low quantities. But I think sometimes when people are getting prolotherapy, they're getting a lot, and they're going to get 6 treatments in 3 different spots, and maybe by the end they've received 50 or 100 or 200 mLs of lidocaine, and maybe it's better to use procaine. So anyway, long
So you use procaine.
So I use procaine, even though it's probably 20 times more expensive, but. And then I use two homeopathics. One of them is Traumeel, the other one is Zeel. Some people are familiar with Traumeel just because it's available as a topical. And it's interesting to me because the prolotherapy guys aren't necessarily homeopathy guys. You know, the homeopathy is sort of a light and subtle type of intervention, and I think that the prolotherapy guys are sometimes the ones they want to get in there and they want to make it bleed and they want to make it better, and I think that's good. But it's interesting just how many of them who are otherwise fairly aggressive, you know, not holistic type people still use the homeopathics because they're just really convinced, and they become convinced over a long period of time that it enhances their results, and maybe they don't understand why, but maybe they don't care, they just know it works better. And I'm certainly in that group. I played around for a while muscle testing different solutions, trying to figure out which ones seem to test best, and I really kind of became convinced that the Traumeel and the Heel both belong in almost all injections. And so whether I'm doing prolotherapy or neurotherapy or trigger points, I'm going to be using pretty much the same solution. I vary the dextrose concentration a little bit, but I always have the Traumeel and the Zeel in there. So Procaine, Traumeel, Zeel, B12, dextrose. That's as old as prolotherapy, maybe, almost anyway.
Pretty standard recipe for.
Yeah. So the dextrose. It's interesting the way the dextrose has kind of changed, though. The movement, I think, is towards lower concentrations of dextrose, simply because the thinking was that the sugar solution caused some sort of osmotic shock to the tissues they didn't like, that suddenly there was this big sugar infusion, and that triggered an inflammatory response that didn't really kill anybody, kill any cells, but triggered a more robust healing response. And it's interesting. There's a leader in the, well, let's call it regenerative therapies, or the whole kind of umbrella that I'm using to describe PRP and platelets and prolotherapy. But there's a leader in that group who is from New Zealand. They call him Liftoff, and he's really advocating for the use of very dilute dextrose solutions and local anesthetics. And he points to some interesting research that shows that there's a receptor on the cells of neurons I think it's called TRPV1, that is sensitive to low concentrations of dextrose. And so he thinks that you can cause an immunomodulatory effect by using dextrose at much lower concentrations. And so it may be that, dextrose has always been useful, but it's possible to achieve that usefulness, that therapeutic benefit, that value, using much lower concentrations that are less likely to, cause people to be more achy and burny in the days after treatment or whatever.
Because it does cause some pain, that high amount, due to the compensatory immune response or so.
Yeah, so depending on your style, you may be really trying to do something that's going to make somebody kind of inflamed for maybe just a few days.
Wow.
And that's maybe okay, because you're trying to recreate the conditions that for recovery that didn't have a chance to play out properly in the first place. So. And
the Procaine, what's the role of that?
Well, it's a local anesthetic, and I think a lot of people think that it ends there, but I don't. And it's interesting. The local anesthetics are generally thought of, especially in the medical community, as nothing more than something that blocks nerve transmission for 30 or 60 minutes, and and that's all it does. But in neurotherapy, which is again kind of, in my opinion, under the same umbrella, the injections are mostly very superficial, not even necessarily under the skin so much as into it. So you could call it like an intracutaneous injection, and so I particularly like neurotherapy in the setting of whiplash injuries and traumatic brain injuries, which often happen at the same time. People get their bell rung and they get a little whiplash at the same time. And so the neurotherapists would treat that as I would with a local anesthetic, not necessarily with anything else. I'd kind of use my same solution for everything. I'd use very little dextrose in that situation, but Certainly people have been getting great results in that kind of an intervention for years just using the local anesthetic, and you could say, well, how could that be? It's going to wear off after an hour. But during that time, it can have a pretty profound neuromodulatory effect. And so even if you just go back to something as simple as what's referred to as substance P, I think P just means pain, but they've been able to determine that in the setting of an injury, you get upregulation of this molecule called substance P, and that helps perpetuate the pain of the injury. And that can be adaptive from an evolutionary perspective, like everything is, for the purposes of disciplining and training the victim, so that they don't go and re-injure things, and so that so pain is there to keep you off of your bad knee or whatever. So you leave it alone, give it a chance to heal. If you're running around and putting a lot of pressure on these ligaments that are trying to repair, you're not going to get a good repair. And so, so anyway, we think that sometimes just having a little bit of relief from the pain because of the anesthetic could downregulate the substance P or cause some other neuromodulatory response such that when the anesthetic wears off, the pain doesn't come back. It may be that there was sort of a self-perpetuating pain loop that now you've broken it. So I think that explains how very often when you're doing even something more conventional like trigger point injections, which again, in my opinion, are under the same umbrella, you can get really lasting benefits from a short-acting anesthetic.
Very interesting. I definitely want to talk more about the neurotherapy and so forth, but let's finish off on the Prolozone, because that kind of,
Sure.
and we'll kind of check off that box. But what's the advantage? Because in the video, again, if folks want to click the link below this video, you did add in the ozone, which I think is, you did it a lot of dexterity associated with like taking things off and all, which is really awesome. But what's the advantage there?
So I think people in doing prolotherapy for years have wanted a little extra edge. They want a little bit more robust response than maybe they were getting just from the dextrose. And just from the dextrose and the local anesthetic combo is sort of the classic go-to. It's still kind of taught that way in most of the training courses. And so they're doing stem cells or PRP or whatever. They used to use some more caustic things that are getting harder to get a hold of, and I think that's okay. Because those are things that potentially, if you get too close to a nerve, if you get them into a vessel of some sort, there's a greater chance of a complication. But if you take those things out, it's pretty hard to hurt somebody with a 23, 21, 25 gauge needle. Mm-hmm. So anyway, the ozone is, I'm kind of dodging your question.
No. So the ozone, so people used to use, basically where we're going there, is that people used to use more caustic agents that could cause nerve damage, but the ozone is it's an evolution, it's novel, there's some therapy there, but it's,
Yeah, so ozone has some interesting properties that lend itself well to prolotherapy. And I think some of those properties are that it's pretty easy to get. You need an ozone generator and an oxygen tank. And those last a long time, so it's not expensive. And ozone, I think, is hurt by by some of its advocates who claim too much. I think that ozone is a nice injectable for prolotherapy. I think it's got some other applications. I don't think it's a panacea, but I think that it has some antimicrobial properties, sure. Where it's probably most useful is where it's fairly well studied, which is that it enhances oxygen utilization. Mm-hmm. And so tissues in the body can make energy the quick and dirty way, which results in the formation of lactic acid. That's referred to as glycolysis. I'm trying to not throw out too many big words, but I think probably most of your listeners have got enough of. And then the more involved, the more time-consuming, but ultimately more efficient way of making energy is called oxidative phosphorylation. And that involves your mitochondria, and it results in the formation of carbon dioxide. Mm-hmm. And so as everybody knows, if you're sprinting, you're going to make a lot of lactic acid, and then you're going to have to stop because your lactic acid levels get too high. And if you're on a marathon, you better be burning oxygen because you can't collect too much lactic acid, or you're going to have to stop. So I think that cells that are inflamed, irritated, injured, damaged, have a little bit more desperation to them. They're maybe reaching a little bit more towards the quick and dirty. They have higher energy demands, so they're reaching towards that glycolysis because it's quick and dirty, and it gets them some energy, but it results in lactic acid formation, and connective tissues are not very well vascularized. They just don't get enough blood, and that's one of the reasons why it takes them so long to heal in the first place. But if you're not getting enough blood, then it's hard to carry away your lactic acid. It's hard to bring in more oxygen or glucose, and so I think it can be counterproductive to do too much glycolysis, to end up with too much lactic acid. And so it turns out that cells that are exposed to ozone have an uptick in oxygen utilization that is more robust and longer lasting than if you were to just expose them to oxygen. So yes, if you expose tissues to oxygen, they use more because they know it's available, but there's a more lasting effect that comes from ozone. And people theorize about why that is, and I think there's a pretty good handle on it. I won't get into it, but basically, if I'm injecting ozone, I'm hoping to make these cells more aerobic, make them use more oxygen so that they are making 36 molecules of ATP instead of 2 for every glucose molecule, so they got more energy currency, more resources available to recover and rebuild and come back to where they're supposed to be.
So that's really fascinating. We talk a lot about like exercise and the ketogenic diet and low carb diets to improve like metabolic health, metabolic flexibility, and by injecting this ozone, what we're doing is improving the metabolic efficiency or effectiveness, however you want to put it, of the cells that may be damaged, that causing the weakened or attenuated, augmented ligament of sorts, which is really interesting. I have never thought about that. It makes a lot of sense.
Yeah, and there's certainly some application for ozonating blood for more systemic conditions, but I think it really sings as an injectable, at this point, nobody's done a head-to-head study. Prolotherapy, Prolozone, PRP, stem cells. So it's hard to say, how they match up against each other in terms of efficacy. But there's no question that Prolozone is cost-effective. Different people charge different amounts, but I think it's possible to make Prolozone therapy pretty affordable for regular people, and that's one of the reasons why I gravitate to it.
And with pretty much every treatment, you'll use the ozone as well, the Prolozone.
I don't usually use ozone if I'm doing the neurotherapy, the intracutaneous, but I do know people who use a fair bit of subcutaneous ozone. But yeah, if I'm going into a joint or injecting a soft tissue, usually a ligament where it meets the bone, I'll use ozone, and I did on both cases.
Yeah, that's really fascinating. Yeah. Awesome. All right, so let's go back to the whiplash. So it seems as though by maybe blocking the substance P and using the procaine and whatnot, we're preventing some neurologic memory of that whiplash. Is that part of it?
Yeah, that's actually a very, very astute description of it. I think that memory is a very big part of whiplash, and not just whiplash. Like the neurotherapists also like to inject surgical scars, and the rationale for that is that the surgeons don't usually use local anesthetic. They knock the patient out and they say, okay, they're not feeling anything.
They're good.
It's interesting because when somebody's under general anesthesia, their basal ganglia, that sort of lizard brain, the inner part of the ancient part of your brain is still fairly conscious and probably very traumatized by the surgery itself, especially the incision, just because that's where most of your pain receptors are. And so there was a study that showed that people used less opiates after surgery if local anesthetic was used before the incision. So you numb up the skin before you cut it open, which seems like a reasonable thing to do. I think that probably you could take that out a long way and just see that you're probably going to have less pain, months and years and decades later. You're going to have less pain if you anesthetize before the surgery. But it turns out that you can erase the memory of that trauma after the fact by just anesthetizing the surgical scar.
Retroactively,
Yeah. And so if you just inject local anesthetic, kind of flood the scar, sometimes you got a chronic pain that goes away.
Can it be a referred pain? Like maybe you had a C-section, could you have back pain or something else? Do you see that?
Yeah, that's exactly right. There are different theories on which the neurotherapy might operate, but that's a good example actually for like hernia scars and C-section scars and appendectomy scars. There are plenty of cases where those get injected and the back pain goes away. And is that a fascial strain pattern that you have caused to let go by treating the scar? Maybe. That's sort of a more osteopathic explanation, but the neurotherapists like that, and I like it too. There may be more to it than that. It may be just purely the memory of the surgery that you might be able to erase, retroactively.
Wow.
And so, probably the same thing is going on with your whiplash injection. I think that some of those chronic whiplash problems come from dysfunctional feedback loops within the nervous system that are self-perpetuating, that are hoping to guard and protect from future injuries while it heals, but maybe it's healed, all it's going to heal until you go in and do some intervention or whatever. So I think that by treating it, you can, especially in the early stages after a whiplash injury, you can prevent those things from setting up in the first place.
And then on the flip side, just coming out and being in front of it. So if you were to have, say, a planned hip operation or a knee operation, you would like if you personally, Shawn, family member, wife or something, would you instruct the surgeon like, all right, let's just get a little lidocaine or procaine beforehand? I know you may not be into this, but here's what I do as a physician. Would you be in that situation, or would you do that?
Yeah, I would. I would ask the surgeon to anesthetize whatever he was going to cut. And, I feel like your viewers may request this of their surgeons who are going to come looking for me and be mad at me, like, I don't want to do this.
Right.
But yeah, I think if you want to do something like that, you have to track down the paper, and maybe we can find it and link it to your site. So potentially they could bring that in and say, okay, I want to use less opiates post-operatively. Would you anesthetize the skin? You might get a more favorable reaction that way.
But I mean, just logistically, lidocaine, or even if they were to use procaine, is it very expensive? I don't think it would be very time-consuming.
Oh, lidocaine's omnipotent in medicine. It's everywhere. It's used constantly, and certainly that's appropriate. It may be appropriate in all situations. I may be spending money on procaine unnecessarily, but that stuff is harder to get. It's from compounding pharmacies. Nobody's going to want to use that, especially if it's just a scar or something. Yeah, one-off is fine.
Yeah. Very interesting. All right, let's kind of finish up with trigger points. You kind of hit on it a little bit, but what's the application? Who is a candidate for trigger point therapy?
Trigger points are a little bit more mainstream, I guess, maybe just because they're paid for. I don't know. I don't think that they're categorically different, but whereas a prolotherapy or a prolozone injection, you might go into the joint. The classic prolotherapy is where a ligament meets the bone. You might treat a tendon too. Some people think you should treat tendons a little differently. Some people don't. The neurotherapy is into the skin. The trigger point injections are typically into a muscle belly, so into the kind of the middle of a muscle. And strictly speaking, you're looking for referred pain that is noticeable when that muscle belly is palpated. And so if you get referred pain, then you're going to try to hit that muscle belly. And some people use steroids. I'm not really too crazy about steroids in that, or frankly any other application. But procaine, lidocaine, they're appropriate. I like to use my regular 6-part solution with or without the dextrose, or with or without the ozone. Usually without. And so.
So it's like an intramuscular injection of sorts with the Prolozone solution.
Yeah, exactly. So I mean, some of the classic trigger points are like the levator scapula and the trapezius, and it's not very uncommon for people to be, to get
they're typing all day, stressed out. And
whatnot. Exactly. And in that sort of a setting, I think that you can do people a lot of good, in a pretty short span of time, sometimes lastingly just by shooting those. So I think that's an appropriate treatment for those people, which is all of us these days, right? It's also true that sometimes, say you've got a shoulder injury, you're going to have, sometimes you'll have trigger points from in muscles that are trying to splint that a little bit. So maybe your rotator cuff's a little damaged, and your shoulder knows it, and it doesn't want you to be, hitting overhead slams in tennis, and so it's kind of causing some restriction. But the muscles aren't really designed to be constantly tight like that, and so they get tired. They build up lactic acid. They're not happy, and so then they're painful, and so that's a trigger point. And by shooting it, it has to relax. It has a chance to recover and to get rid of the lactic acid and to and to get back to it's not previously, it's get back to baseline, and it, if you're not sitting at the computer anymore, maybe it gets back to baseline and realizes, okay, I'm fine, I can stay in my normal state. And if you've still got a shoulder injury, that's the situation where that trigger point's probably going to come back, and if you're the doctor, you should be looking for, okay, is there some other injury that's triggering this trigger point to come back? And now I need to go looking for that, and maybe treat the shoulder or something like that.
Yeah, wow, that's really fantastic. So kind of final question here. If folks want to find a really good, someone that does Prolo, like a colleague of yours, is there an online resource of integrative regenerative therapies or a board, or like how do you find someone that knows what they're doing?
Sure. The AAOM, the American Academy of Orthopedic Medicine, I think. I'm a member. I should know what the name is. I don't ever seem to get any referrals from that website. So I guess people aren't looking there, but they should be. I think that's a good place to go. The Hackett-Hemwall Foundation is also good. I think they're still maintaining their website, and so that's a good foundation that does a lot of great training courses. So when I learned how to do prolotherapy, we went down to Honduras and just got to practice on dozens and hundreds of real people with real problems, and I thought that was a great way to train. That's hard to get in stateside on cadavers. It's not the same. Yeah. But yeah, so Hackett-Hemwall Foundation, AAOM. I get a lot of my referrals from the AAOT, the American Academy of Ozone Therapies, .org or .us or something like that. And so that's mostly an organization spearheaded by Frank Schellenberger, who's teaching the Prolozone courses, most of the Prolozone courses that are going on.
Okay, so I'll put the links below this description so people can find that. So a few final questions before we part ways. We want to get to know you as a practitioner a little bit more on a personal level. So if there's one herb, nutrient, or botanical, Shawn, that you just really couldn't live without, we're going to exclude vitamin D and omega-3s. What would that be?
Kind of lukewarm on both of those anyway.
Yeah,
so.
Good, all right.
No, they're both wonderful. I recommend a lot of apohepat. It's APO-HEPAT. It's a German homeopathic, I guess it's technically a spagyric remedy that's designed to help with toxicity. And so when I muscle test people, I see that come up more than any other single thing, just because I treat a lot of chronic infections, and chronic infections live and die by their ability to stay ahead of your immune system by secreting toxins that cause inflammation and immune dysregulation, and that's a very safe and well tolerated and cost-effective way of helping people to move toxins. So I use a lot of apohepat. I think it's really helpful.
That pecana, right?
It's pecana, yeah.
Yeah, that's really good line I've heard from you.
Yeah. There are others that it's sold in a trio by some people. Renilix and Iteries is part of a bundle pack or whatever. But I think the apohepat is the most important. It's the one I use the most.
Awesome. All right. So morning routines. We know that a lot of successful people like yourself have a set of rituals or routines that they do in the morning. Let's talk about what's your morning routine. Maybe food that you eat or meditations of sorts. What do you like to do in the morning? I
don't know if I'm the right person to ask about that. I probably should do more in the morning. I know I should, but I don't know. I have children and things. I'm busy looking after them in the mornings. But my wife and I do have the same smoothie every morning, and so that's a big part of our routine. And there's nothing super esoteric about it. We do I'm using like a vegetable-based protein with greens in it, and a Greek yogurt. I actually would like it if it was like high fat, but usually the Costco's only got the no fat, so whatever, if I gotta go to Safeway, I'll get a bunch of the high fat, fine. Frozen berries and well, if we're taking tinctures or herbs, we'll maybe throw them in there if they don't taste too bad. So I think a smoothie is a really good way to start the day. But you turned me on to bulletproof coffee, actually, and my wife likes coffee, and if I drink decaf, I can still sleep. So we do that a fair bit with coconut oil, and I like that too.
Yeah. What have you noticed just subjectively since doing more like fatty coffees or fatty teas, things like that? Anything?
My body really likes fatty stuff, and so, your listeners are probably not new to this, but yeah, so fat's just been vilified in the most terrible ways, and I'm sure you've talked about this on other podcasts, but yeah, my body really responds well to fat and not so well to sugar, and so, whether it's that Irish Gold butter or coconut oil in my coffee or whatever, I'd say bring it on.
Yeah. Okay, so second question, semi-final question. If a patient was going to come in or go to another practitioner, either to see you or another practitioner for regenerative-based therapies, ideally, how would they optimize their body, or nutritional standpoint, stress reduction, not taking NSAIDs like we talked about, so that the therapy is really effective? Like, what are some tips you'd like to offer to people?
I think that people probably should listen to their bodies more. I know that sounds like an obvious thing, but on TV, you see every day commercials. It's like, oh, yeah, I used to have back pain or whatever pain, and I just take Advil and I ignore it. And I think that's how people end up with more problems down the line is if it hurts, your body's trying to tell you something. If you've injured it recently, try not to do things that make it hurt. And that sounds obvious, but I just think a lot of people don't do it. And if it's a chronic thing, an injury because you hurt or tore or sprained something and it just keeps bothering you, I think that's a good time for to think about regenerative injection therapies, if you want to call them that. This umbrella that I think RIT is a good use of that term. But I also think there's something to be said for you are what you eat, and so if people break a bone, yeah, okay, you could take calcium, but better yet, take bone meal. Like you can get bone up at the health food store. There's a great Zymogen Osopan, is that what it's called? Or
yeah.
Eat. So that's not just going to have the calcium in it. It's got all the other minerals and structural proteins that are going to go into the bone, and so. Ligaments are probably not so yes, something like that. Okay, maybe you didn't break a bone, but you're still going to have a lot of those same sort of foundational healing elements in a ligament, in the structural components to a ligament. There's a product called Ligaplex from Standard Process that I sometimes use, but I'm not necessarily in the habit of having people eat a lot of or take a lot of capsules if they're pills if they're coming in for that kind of a thing. But yeah, bone meal, protein,
clean real food, basically.
Clean real food,
no
yeah.
processed. Yeah. Because you want your body to repair. That's kind of the whole point.
Yeah, you want to make sure that it's got the resources that it needs, and that means the right balance of amino acids, and it's hard to get that if you're a vegetarian, and especially if you're not eating eggs or anything like that.
Yeah, so. Very interesting. Okay, so the next question has to do with what you feel would be the most powerful lifestyle or health tip that societies on a societal level people could take part in. So if you were to bump shoulders with a politician, president of the United States, parliament member from European Union of sorts, in an elevator, what would you tell them if they turned to you and said, Dr. Naylor, I'm working on some ways to improve my community. What should I know? What would you like them to do?
Well, again, this is probably not news to your listeners who are probably already pretty health conscious people, and I think most health conscious people in this country are already not consuming terrific amounts of high fructose corn syrup. But if there's one thing that is going to bankrupt this country through healthcare, expenses and cause tremendous morbidity and mortality and obesity and all of these terrible problems that we have in the healthcare in the United States. High fructose corn syrup and sugar. We're not evolved to consume anywhere near the quantities of that stuff that we're consuming right now. It's totally, in another 150 generations, maybe if we live that long,
we'll adapt.
That will adapt. But right now, you can't do that stuff. And so unfortunately, we have very strong lobbies for agribusiness and Coca-Cola and Pepsi and stuff like this, and they're just now starting to maybe we got a bit of an obesity problem. Well, how much research has had to come down? How big is the stacks of the the papers that show that that stuff is really bad for you in order for them to be starting to come around to like, maybe we need to acknowledge this. But I think, heck, if you're going to be subsidizing corn, so it can be used for ethanol or whatever, fine. I mean, get your subsidy back by taxing high fructose corn syrup.
Yeah.
I know that people don't like taxes, but I thought Bloomberg was onto something with not wanting to have extra large sodas. There's no reason to consume that much soda. That's a bad idea. But I think it'd be better if you just you taxed high fructose corn syrup way back at the source, and a lot of people are going to consume it anyway, and probably the end product isn't going to cost that much more. But you could fund some healthcare or something with that.
So instead of giving the companies that grow the corn and so forth favors and subsidies, maybe make it more expensive to make those products, so that to maybe discourage them from growing it. And
I think that they should tax high fructose corn syrup or sugar, before it goes into your food, because we shouldn't be consuming it. It shouldn't be in our food, and you can't really tell people what to eat; they'll revolt. But if if you got to raise taxes for something, why not try to use your taxes, your taxation policy creatively in a way that influences behavior in the right ways.
Beautifully said. Love it. Dr. Naylor, thanks so much for coming on the show. If folks want to connect with you, what's the best online resource?
Yeah, my website is www.soundclinic.com, and that's a good way to find my clinic. So
awesome.
Yeah.
All right, folks, thanks so much for tuning in and watching it this far. If you enjoyed this video, please give it a thumbs up and subscribe to the channel. If you want to learn more about Dr. Naylor's practice, please click the link in the descriptions below this video. And thanks again for tuning in.